speakers. That is Professor Amber Simpson. Professor Amber Simpson is the Canada Research Chair in Biomedical Computing and Informatics, and Associate Professor jointly appointed in the Department of Biomedical and Molecular Sciences and School of Computing at Queen's University. She is an affiliate of the Vector Institute for AI, as well as a senior investigator at the Canadian Cancer Trials Group. Dr. Simpson is the director of the Center for Health Innovation, a joint venture with Kingston Health Sciences Center and Queen's. She received her PhD in computer science from Queen's and was a postdoctoral fellow in the Department of Biomedical Engineering at Vanderbilt University. Recently recruited from a faculty position at Memorial Sloan Kettering Cancer Center in New York, she holds research funding from the National Institute of Health, as well funding from all 3 Canadian research councils. Dr. Simpson is an American Associate of Cancer Research and Pancreatic Cancer Action Network award holder and a chartered member of NIH Study Section, which recognizes her innovations in biomedical research. She specializes in biomedical data science, focusing on developing novel computational strategies for improving human health. So with that, I would like to pass the floor to Professor Amber.
How does that look? Can everybody see that? Trying to see people at the same time.
Looks good.
Okay. Okay. And I can see everyone while I do this. It's always hard to kind of speak into the abyss of Zoom. But thanks so much. Nice to see everyone this morning. Let's see if I can advance this. Yes. So thanks, Amelia, for going through my disclosures as well. I hold funding, but I don't have any funding from any companies. So my perspective is that I worked for a really long time as a computer scientist at a high volume cancer center. So cancer centers are interesting from a data perspective because they contain rich, deep data on cancer patients, and typically only cancer patients, right? You don't see a lot of necessarily healthy patients coming through cancer centers, although you can. And those patients tend to have lots of imaging, maybe some genomics. And my experience was in the US, where it's single institutions with closed data that's difficult to share because of a variety of reasons that I'll talk about. Now I'm part of the Canadian Cancer Trials Group. This is our equivalent of EORTC. And we coordinated centralized cancer trials across Canada. And we centralize clinical trial data and specimen, and we make that data and specimen available for research purposes. And we're working on building a data science platform to work with that kind of data. And then I also work a lot on the Ontario Health Data Platform, which I'll talk about as well. But it's population level data within a single health payer system. So 14 million people in the province of Ontario. It's a data platform for research, but very different data, population level data, meaning that when you had your COVID vaccine, your COVID vaccine data would be in this database, but we wouldn't necessarily have deep data on 14 million patients. So I've seen kind of all these different versions of data and dealt with each of them, and they all have their own challenges. And I also like to push back on this concept that computer scientists don't really cure cancer. MDs do. I think we have a role in this, and I think if we don't accept that role, we're not accepting our responsibilities to the world. So today's talk, I'm going to talk just briefly a little bit about the importance of this to patients, and then talk about the medical segmentation decathlon story. So why is image segmentation so important to patients? And geez, I had really dumb transitions, huh? It's always funny when you actually play your presentation for everybody. But anyways, so for me, I'm a cancer researcher. And so we think a lot about RECIST criteria as one example of image segmentation. So RECIST criteria are published rules for assessing disease burden in imaging. They're performed by a radiologist, and they're documented separate from the radiology report. And you can actually see the RECIST measurement on the scan here to the right. It's a unidimensional measurement. Sometimes you can have 2 dimensions depending on which version of RECIST that you're using. But this is essentially an image segmentation problem, right? So So we need this because oncologists recognize that they needed a reliable and reproducible method to assess treatment response so that they could evenly judge and benchmark cancer drugs across different clinical trials. And these are important to patients because it determines whether or not you continue on your current treatment regimen and whether you move to a different one. And that's huge, right? So this is a really classical image segmentation problem and has a huge implication for patients. And it's super interesting because I think we're going to talk a lot today about benchmarking. Like the reason they came up with RECIST was because of benchmarking. They really wanted to benchmark across all these trials. And if you go back to the very original RECIST paper that was out there, they talk about how investigations are frequently reported in a way which makes it difficult for investigators to compare the results with each other. And that's exactly what I think we're trying to get at with these grand challenges, and that they needed a way to develop a common language. And I think that's pretty in sync with what we're trying to do today. From my perspective, so we do a lot of work in the lab, taking routine imaging and showing that you can predict survival from routine imaging. And I know the UPenn folks are here today too, and I'm sure they're going to talk about this. But this concept that if you have a lesion, and maybe you can see the lesions, these are pancreas cancers. So if you have the lesion and you have it segmented, you can evaluate the properties of that lesion and determine who's going to have a good outcome. And that's super important. And so there's challenges to data sharing, right? And I think we're aware of some of them. So there's a huge siloification that's happened of health data over the decades. These challenges are different in different countries, but I can share some of the things that I've experienced. So, one challenge, and this is particularly true in the US, I would say it's less true in Canada, is that clinicians have built their research careers on patient data in the US. And so they've likely paid to collect that data, to annotate that data, and they consider it their data. And so to then take that data and want to share that data, you're telling them that you're going to take everything away from them. And that's a really hard thing for them to hear. So from my point of view as a computer scientist, I'm like, rah, 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 let's share data. But that's not necessarily true of all the other stakeholders within the patient care space. Patient data is also not accurately captured in hospitals. So people think there's all these codes that you can use and you just look up people. And that's sort of true, but those codes are based on billing codes. So like ICD-9, ICD-10, and now ICD-11, they're based on billing. And often, this is true in Canada, that code gets applied based on, the admin in the office. So it's not necessarily a ground truth label that you're adding to the data. It's a label that is there for billing purposes, not for the purposes of creating a machine learning model. And then, so something I've dealt with a lot in the past is this idea from folks that, why should we give our data away for free and pay participants to work with the data when we worked so hard to generate the data? So I remember the first challenge I ever did, the MDs were shocked that we were going to offer prizes. Because they just thought, well, what, like the prize is the data, we're giving them the data. And so that was really interesting. And, it's all about socializing these different concepts to different stakeholders. And that's, I think, what challenges are all about. But there's also no reward systems for hospitals to share data. That's going to change in Canada because we've linked billing. We're starting to link billing to actually making data available. And our health system is a bit different in that regard. And then, of course, protected health information is notoriously hard to remove. So a good example that Ron Summers from NIH talks about. So he made those, I think it's 200,000 x-rays available for a challenge. And he had to actually go through them because manually and double check each of them because his colleagues from the NIH would get a scan and wear their name badge in the scan. And so the badge was actually getting burned into the x-ray in a way that they just really didn't anticipate. And he actually had to go through and check all of the 200,000 x-rays, which is crazy, right? And then, of course, there's this lack of interoperability of imaging data generally, a lack of standardized pipelines for sharing and anonymizing data. So I just put I'll talk about it later, but I just put a data set on TCIA which is the Cancer Imaging Archive in the US. And it took me 2 years to get there. And it took me, like 2 postdocs, and it was a thing. And I have, I have white hairs that I'm naming TCIA now. I think we've got a lot more pipelines now, but it's just not perfect. And then there's huge fines for leaking PHI. So I have collaborators at Columbia that were doing a radiology course. So they put up images and then the radiologists worked with them. And they didn't strip the PHI from one of them, and they put PHI up and they got a $4 million US fine. Who pays for that kind of stuff? Okay, so let me talk a little bit about the medical segmentation decathlon, the origin of this. And so the actual challenge has been published now. I think just last year we finally published it. It's in Nature Communications. You can read about it. It's, an extensive and exhaustive analysis of all the data that came from that. And the origin story is really that George Cordoza and I were at Mackay in 2017, I think. That's how long ago this was. And somebody introduced us because I was complaining that in 20 years of going to Mackay, we still hadn't solved the medical image segmentation problem. We hadn't really come close to solving it. And I would go to these meetings and I would see these posters where people had just cracked data that didn't represent the clinical context. At the time I was in New York, I was sitting on all of this data. And so the conversation is, it's crap. Can't we benchmark? Like, can't we make some more data available? And this was 2018, right? So 2017, 2018. So you were starting to see a lot of challenges. There's a lot more now. And so couldn't we just solve the medical image segmentation problem the same way we solved object recognition, by getting data out there? And, George said, yeah, that's great, but nobody has that kind of data. And I was like, actually, I have a lot of data. We've spent a few years now annotating that data. Let's see what we can do. And so, yeah, this was, the challenge, as many challenges are, was inspired by the object recognition problem, which I probably don't have to tell this group about. But given an image, determine what's in the image. This led to the creation of ImageNet. This is thought to be the thing that really accelerated machine learning. It's brought us self-driving cars. It's brought us all of these things. And it's because 10 million images with 1,000 labeled classes were made available. At the same time, there were revolutions in hardware, but if the data weren't available, they would not have moved the field forward. Right. So this was huge. So how do we do the same thing in medical imaging? And so a bunch of us got together and said, okay, how are we gonna do that? And so we made the medical segmentation decathlon. And so we rolled it out at Mackay in 2018. And the goal was to develop a semantic segmentation algorithm, or a learning system that can solve 10 segmentation tasks separately without human interaction. So you couldn't refine your algorithm between tasks. It had to learn. It had to learn based on the data that were available. And the idea was that we would make an ImageNet for medical images. So the values that I kind of brought to this were to democratize access to the data. We realized, at the end of the challenge, that it was access to hardware that also needs democratization. So at that time, NVIDIA, they can still do it, but could just trounce anybody in these challenges because they just have better hardware. So what was taking other people 4 weeks to train, NVIDIA trained. They had some undergrads that worked on it for the summer, that were there for the summer working at NVIDIA. They worked for the weekend and got a great result because they just had way faster computers than everybody else. We also wanted to remove barriers to image analysis. So prep the data in such a way that if you were a machine learning researcher, you didn't have to deal with DICOM, you didn't have to deal with resampling images and doing all these very complicated things. We wanted to make it so that you could just download, you could download them, and you didn't need a history of working in image analysis. And we took that from ImageNet, right? That ImageNet was very easy in that sense. And then keep the data openly available long past the challenge, and to think carefully about the licenses with which we use to make that data available. And so the data, like I said, it was 10 data sets. My group provided 5 of them. The other 5 were already publicly available to some degree, but they had a part of them. Actually, no, they didn't have a data set that was withheld. So the other 5 were publicly available. So that's why they were in the training data, not in the test data. And so I shared about 2,600 CT scans altogether, all annotated. And the idea was that you had a phase 1 where you had 7 different tasks, and then we had a mystery phase where they didn't know what the tasks were. And that was the phase 2, and that was the true testing phase. Within each of these data sets, there was also a training and test, and then there was this these 3 mystery tasks that we held out. And so we had training data from the public repositories, we had testing data that was my data, that was private data. From my perspective, I worked with our information security department for a year to explain to them that NIFTY is not DICOM, that that with NIFTY, there's no concern for metadata because it just doesn't exist. Like there are no DICOM tags because it's just not DICOM. And so that was like a huge thing, right? Like that you had to work with the radiology department and really explain this concept. The license was a permissive copyright license, so you could copy and redistribute the material in any medium or format, remix, transform, and even do that commercially. And then what we learned was that sharing segmentations was somewhat easy, but for me to share outcomes was going to be a huge pain in the butt, because as soon as you tell clinicians you want to release the survival data, that's kind of their bread and butter, and they don't really want to release it. And you can find, we have a nice paper written up about the data that's on archive. And so to give some context to how the data are prepared and how much time it takes, ground truth segmentations were generated as part of various papers that I had worked on. So we had really great radiology and surgical fellows. So these are people that are trained for an incredibly long time and really understand anatomy. They did ground truth segmentations. We had, so for example, for the liver segmentations, there are some pretty good, at the time, there were some pretty good liver segmentation algorithms out there. So we used those, and then the annotators just had to refine them, which saved a lot of time. But just, to put that into perspective, just downloading a CT scan from PACS takes anywhere from 5 to 7 minutes, especially a CT angiogram. They have a lot of slices and it just takes a long time. So 1,100 scans times 5 to 7 minutes each is 93 to 130 hours of expert time. And then manual segmentation takes even longer, about 30 minutes, which is, we probably had about 30 days of manual segmentation in this. And despite that, some of my colleagues on the challenge thought the clinical collaborators shouldn't even be included in the authorship, that the people that did the annotations, oh no, we're not going to put them in. Like, really? Like, there was so much effort that was put in this. Anyways. And so look, the Medical Segmentation Decathlon results were amazing, right? And you can look these up. Achieved state-of-the-art performance across many different organs and disease pathologies. And brought us NNUNet, which I think is still the current standard in image segmentation, and certainly in generalizable image segmentation. And that's pretty fantastic. We had prizes by NVIDIA. We did like this Oprah style thing where we put stickers on the bottom of seats, and you looked under your seat, and if you had an NVIDIA sticker, you got a graphics card. This was at a time when it was, well, I mean, it's still this time, but it was hard to get a graphics card. And so to be given one, at a conference was great, but it was Oprah style, right? Like you get a graphics card and you get a graphics card and that kind of thing. And people loved it. The data availability. So this wound up going into NVIDIA's Clara healthcare platform and their medical imaging SDKs, which is still there, right? So if you're training on many of the things that are out there right now, this data is buried in it in some way. And then of course it yielded NNUNet, which is pretty fantastic. So lessons learned. So I'm going to be pretty honest about how this went. So really great challenge, moved the field forward, but it was hard, and it's hard to work with people, and people have to understand each other's points of view. I think this is something that the BRATS guys have done really well, but agree on authorship before the work begins. I thought we did that, but it still seemed to change as we went along. Commit to a publication schedule, like say, okay, this is how we're going to do this work. And be clear about conflicts of interest. This didn't happen. And I didn't realize that it was happening at the time. But, in oncology, for example, MDs have to declare competing interests. They have to say, I'm sitting on this board for this drug company. I received this money for this trial, for this drug. We don't have to do that in AI, right? And AI researchers have a huge number of conflicts of interest that they're bringing to the table. And you don't know that they're actually being paid by companies. So there were folks at the company at the table for this that actually had, competing interests, because they had companies at their back door that were saying, hey, get us access to a whole bunch of data. And then I'm thinking, that we're doing this academic collaboration, but it wasn't really an academic collaboration. So I would say in retrospect, that was a big deal for me. And it's also really hard to work across time zones. So there would be emails that would go around at like 2 a.m. my time for meetings at 4 a.m. my time. I would check my email at 8 a.m. my time and be like, oh, I guess I missed another meeting, but I had a very good night's sleep. So that kind of thing it's just a practical thing of, it's hard to bring people together, and it's hard to value each other's time and make sure that everybody's included and that all the stakeholders have their interests met. I'm going to talk just really briefly about data platforms. So I think in COVID-19, a lot of things changed. And one of them is that we got more data platforms came. And so this concept in the US is that you make the data publicly available. Other countries are not thinking that way, right? And obviously Europe's not thinking that way. And so this is my old Nasty Health card in Canada. This connects me. This gives me a number that defines like who I am in the healthcare system. So it gives me a unique identifier. And so every time I go to the doctor, this card is presented and is attached to my medical record. And so in the province of Ontario, we're a single payer insurance called OHIP, and our hospitals are not-for-profit private corporations. So it's a little bit different than the US. And so in the pandemic, we spun up a federated health data platform to get data out to researchers so that we could actually solve COVID-19 questions quickly. And it's similar to the UK Biobank, but I think the biggest difference, so UK Biobank is really super deep data, longitudinal data on a subset of patients that have been prospectively consented. This is our Ontario Health Data Platform is population level data. So it's anytime, you're getting a lab test done, anytime you're getting, you're going to your family doctor, anytime that you're, getting something done in the health system, that it's gonna hit into this platform. It's not complete data yet, but we're working on it. So it's kind of like a complex web of data, lots of missing data, because not everybody gets, every test all the time, but it's the tests that are available. So it's pretty cool, but it's a very different thing than what I'm talking about when I'm talking about just releasing big data sets publicly. I hope that we're on the right side of history with releasing all of this data publicly. I'm a little worried now that or maybe not, because you can now identify people, right? So we've put all this MSD data out there, and it's going to be entirely possible at some point to identify these folks, because if you get a little bit of their clinical data, you can actually triangulate who these people are, right? So that's a concern, and that's something to really think about. And I think about that a lot now. We just had a new data set released on TCIA. Go look at it. It's a nice data set. And we'll have the paper out for that pretty soon. And just a thanks to my lab, my students, and also thanks to my former colleagues in New York that really helped prepare this data and helped bring it forward so that we could publicly share it. And thanks for the invitation.